limiting lymphedema?
I always love getting the sexiest topics. So primary lymphedema, it occurs after having no surgery and is, iatrogenic in very few cases. And obviously in the U.S., lymphedema occurs much more frequently in the upper extremity after surgery and still most likely after mastectomy. But that's not actually what we're going to really talk about today. Because it's not what we see in our offices, and I don't think most of the limb specialists and limb salvage people, the cardiologists, interventional radiologists, vascular surgeons, that's not really what we're getting referred. So what happens is that these folks really have some correlation to weight, and we see certainly in the U.S. an epidemic, obviously, in our obesity population. So we have a lot of folks who are large and have a primary lymphedema, usually lymphedema preco, by having it start before age 35. Filaria, et cetera, are very uncommon in our population. Interestingly, all the research in regards to patients having a large amount of lymphedema being associated with weight is also in patients who are post-mastectomy. And there's not a paper out there that looks at obesity as a lower extremity risk factor. It all is post-mastectomy. So the mainstays of therapy in 2017 have not particularly changed. The early and frequent removal of proteinaceous substances with pumps, stockings, exercise, and elevation must be followed. To maintain the limit the smallest size possible is our goal, and the idea here is to keep the proteinaceous fluid from accumulating. And again, that's not anything all that interesting, and we don't have a great endovascular approach to that. You can certainly take a look for May-Thurner syndrome, you can look for venous reflux, and you can potentially laser some veins. And most of the time, if I've had people have that done, they come in and they're not any better whatsoever because they do have lymphedema. So there are grades, and the reason the grades matter somewhat is mild edema and moderate edema are really the diseases that do have surgical options for them. These are relatively busy looking slides, but what we actually see in the office most of the time is gigantic edema, grade 4. And if you read the definition of that, then in this stage, lymphedema, the affected extremities are huge due to almost complete blockage of the lymph channels. Now, we do not do lymphscintigrams and we do not do lymphangiograms on these patients because their reconstructive options are functionally none. And the folks certainly in the New York environment who tend to do this, and really worldwide, tend to be the plastic surgeons who do microvascular anastomoses. And we did have a very robust group down at the Beth Israel campus a while ago who were doing some of this, but that's really focused on the moderate edema. And functionally, these are patients who their edema gets better in the morning and you can compress their ankles down to almost normal sizes. So that's a population that obviously does not have life-limiting changes, but that population can benefit from lymphaticovenous anastomoses and vascularized lymph node transfer, both which are in the right hands do somewhat well. There is the option of doing basically a subcutaneous procedure very much like a liposuction that also is usually done by plastic surgeons. Now the stages and grades are somewhat different, but stages really have to do with what's reversible and what's not. And again, stage 1, spontaneously reversible. These are the patients who usually upon waking in the morning have a limb that looks pretty good. And spontaneously irreversible is still these folks who have a spongy leg. And both these stage 1 and 2 are still possibly patients who would be appropriate for some form of vascular intervention. These are the population that does indeed possibly benefit from having a lymphscintigram first to see that they actually truly have lymphedema and where a blockage may occur, and then even potentially a lymphangiogram prior to reconstruction. This is a very select group, however, and in general, in most populations, it appears that maybe 1 in 100 patients with lymphedema is a possible candidate or gets some procedure like this. As you may expect, there are not large prospective trials in regards to this. Lymphostatic elephantiasis is really the premise of this talk, and in this stage of swelling is irreversible, and usually the limbs are affected and are very noticeably large, and the tissue is very hard. And in general, they'll go under some form of debulking surgery. This remains controversial because the risks may outweigh the benefits, and further damage done to the lymphatic system may make the lymphedema worse. Unfortunately, with that caveat, I don't really believe that, because if the patients are young and have this problem, certainly under 40, and it's really affecting their lifestyle, there is no option for them, including people say, well, we'll get them custom garments. Well, in the reality of that, that's not available in the U.S. based upon insurance criteria, and the garments aren't even large enough to work. So our plan is following this as follows. Stage 1, we use compression wraps, obviously, followed by compression garments. These are fairly easy to modify, and you have to talk to the patient and get them to buy into therapy. Stage 2, compression wraps for 4 weeks while getting the paperwork together for pneumatic compression pumps is basically what we do, and we recommend an hour and 15 minutes twice a day with afternoon exercise and a compression garment to be worn in between the compression pumps. These may be patients, if they're under 40, who will get a lymphscintigram, a lymphangiogram, plus minus, and refer for reconstruction. However, stage 3 patients, we consider debulking, which involves a 1-week hospital stay, 50% chance of wound complication, and all patients are drained and have incisional negative pressure wound therapy placed, and this is an open operative procedure. They'll still need postoperative garments. So for our microvascular lymph vessel reconstructions, which I do not do, our lymphovenous anastomosis, microvascular anastomosis is often done under a operating magnifying scope with 9/0 suture, and transposition sometimes can be done with lymph nodes, and both of these are reported with interesting results, but the selection criteria are very, very high for these patients. However, when a patient can't walk, they might need an operation like this. And in this case, we take off a 40-pound mass off the inner portion of a patient's thigh, reconstructing it over drains and putting it back together, and they will have some component of complications. However, this patient had been unable to walk. This particular patient had been unable to walk for 2.5 years, and he is now ambulating. So we do get some benefit to this, but this is a major reconstructive surgery. In surgery, we stage the leg. Basically, 30% or 33% of those patients in our population that we've done this on have had previous bariatric surgery. The operation's really done not quite like the Linton procedure that was originally discussed. We don't go all the way down to fascia, and we do not skin graft these patients. We do it more similarly to a mastectomy, tapering down to the fascia, and we do not expose large areas of the underlying fascia. And as you see these blue lines on the screen, we'll stage the leg, and we never do all 3 areas of the leg simultaneously, certainly, and we'll usually separate them by about 2 to 4 months apart to allow for healing. And it's rare that we have to do all 3 segments, which would be upper inner thigh, lower medial leg, and lateral leg. These incisions almost always have to cross the knee. The ankle itself is very difficult to improve, and that might be the only place that will go all the way down to fascia. During these operations, there can be massive volume shifts of fluid, and the patients often lose 6 to 8 liters of fluid from just lymphatic fluid drainage, despite having hundreds of ties at times used. There's also, just for U.S. folks, there's actually no CPT codes that go along with these procedures, and they're very poorly reimbursed, so they're not very interesting in that sense. Thank you very much.